Thank you, Nick, and thank you to everyone who's joined today. So I'm going to talk briefly about tafenoquine and the pharmacometrics of tafenoquine and trying to optimize the tafenoquine dose. So currently, tafenoquine in adults is recommended at a 300 milligram dose. There's also a pediatric dose from 2 years and older. And to get tafenoquine, you need to have more than 70% G6PD enzyme activity using a quantitative point of care test. And as mentioned by Alison, this is now recommended to be given with chloroquine only. So 300 milligrams, that's 2 tablets in the current formulation, which are 150 each. And then across the vivax endemic world, really, from my understanding, only patients in Brazil are currently getting tafenoquine, but hopefully this will expand. Now, the question we had is whether or not 300 milligrams is in fact the right dose. And as mentioned by Alison, there was this trial in Indonesian soldiers, the Inspector trial, which showed quite poor efficacy of tafenoquine when given with DHA proparaquine. And there clearly are some drug-drug interactions which are possibly important, but another important feature is actually the dose, and underdosing could possibly explain some of these results. So very briefly, to have a kind of, our sort of causal model, as it were, that's guiding this analysis. Tafenoquine's most likely a prodrug, so the parent compound isn't doing much. It needs to be metabolized in the liver, and then these active metabolites are driving the key clinical outcomes. So that's the hemolysis, so oxidant hemolysis of older red cells, especially in G6PD deficiency, and then killing hypnozoites, and then also production of methemoglobin. And so, this is these are all kind of correlated with each other, these outcomes. Now, in our work, we've looked at 2 key questions. So first of all, the relationship between the dose, so that's a body weight adjusted dose in milligrams per kilogram, and whether or not you get a recurrence, say within 4 or 6 months. And also, as Rob mentioned, and this talk is really very sort of parallel to Rob's talk, is the relationship between that dose and acute hemolysis. And this here is going to be restricted to patients who have more than 70% G6PD enzyme activity, because that's the data we have, the clinical trials, that was the key inclusion criteria. And so we've done an individual patient data meta-analysis. This includes all the pre-registration trials done by GSK, and the objective is to try and determine an optimal tafenoquine dose. So very briefly, there are 4 trials that we've had access to. 3 of these are in vivax patients, so detective phase 2 and 3, and then the GATHER trial, and then 1 phase 1 trial in healthy volunteers. And looking at the vivax patients, in those who were followed up for more than 1 month, we've got data in over 1,000 patients. Over 600 of those got tafenoquine. Most of them got 300 milligrams, but there are also some who got higher and lower doses. And about 250 got primaquine, and the rest got no ataminoquinolone treatment. And we've also got rich PK data and also quite rich methemoglobin data. Now, if you just look at, very simply, the time to first recurrence in this pooled data set, as in Rob's data on primaquine, there's a very, very clear dose effect. So the higher the dose of tafenoquine you give, the less likely you are to have a recurrence by 6 months. And 5 milligrams per kilogram, so that's a 300 milligram dose in a 60 kilo adult. That's very approximately equal to the low dose primaquine regimen that was used as a comparator in these studies. So that's 3.5 milligrams per kilogram given over 2 weeks. If we put all these data into one sort of dose response model, so something known as an Emax model, so this assumes a sigmoid relationship between the dose and whether or not you, the effect on reducing recurrence, then again, you get this very, very clear dose response. And this is using data from over 1,000 patients, and it's extremely clear that weight is a primary determinant of efficacy. And then the 5 milligram per kilogram dose is approximately equal to low dose Pharmacometric. And if you look at this, say, in a logistic regression model, you get very similar odds ratios for equal percentage increases in both the Pharmacometric and the tafenoquine dose. So they really are quite, very similar to each other. And then if you turn this round into a, saying, well, what's the effect relative to the biggest dose I could ever give? So in these trials, the largest dose was approximately 15 milligrams per kilogram. No one got higher dose than that. So if you say, well, 15 milligrams per kilogram gives me my maximum dose, 0 gives me, 0 gives me no effect, 15 gives me 100% of the obtainable effect. And then what's the relative effect in between those doses? And under this, you get that 5 milligrams per kilogram is approximately 70% of the maximal obtainable effect. But the key point here, and this is really important, is that it's on this very steep part of the dose response curve. So, the mean weight in these patients was about 60 kilos. So they're on average getting 5 milligrams per kilogram, but small deviations in weight from that ends up in small deviations in milligram per kilogram dose, and actually quite large deviations in efficacy. And using this distribution of patient weights from these trials, we estimate that the 300 milligram dose gives you about 15 to 16% recurrence by 4 months. If you increase that by 50%, so that's just one extra tablet, then that would reduce it down to, say, 7%. So that's more than half. And put in a different way, for every 11 patients that you gave that one extra tablet, so that's 450 instead of 300, you would avert 1 recurrence. So it's quite a good number needed to treat. Now, the flip side of this is obviously hemolysis. Now, we've obviously the data we have are in patients who have a G6PD enzyme activity greater than 70%. And in these patients, you do see a slight relationship between the tafenoquine dose and the nadir hemoglobin, but the effect is very, very small. So for every milligram per kilogram increase in tafenoquine, you get a reduction of about 0.02 grams per deciliter. So for a 300 milligram dose, you might expect a 0.1 gram per deciliter reduction. And for a 450, that's 0.15. So that's less really than 1% reduction in hemoglobin, which is absolutely tiny. Now, this is when you're using one of these quantitative point of care tests. The effect of these doses in fully deficient patients, so let's say less than 30% activity, is basically unknown because we have no data. So coming to the key question, which is what is the optimal dose? And optimality here is defined as this trade-off between the risk of hemolysis versus the benefit of curing patients from, curing them from their relapsing infection. So imagine if you were going to compare, say, the 300 milligram dose versus, say, the 450 milligram dose in the context of using a quantitative point of care test. You might imagine, well, suppose you have 1,000 symptomatic patients who come to a clinic, and G6PD deficiency is about 10% allele frequency. So maybe 85, 88% of those patients could be eligible for tafenoquine treatment. And if you give them a 300 milligram dose, you might avert about 309 recurrences. If you increase that to 450, you're going to increase the number of recurrences averted by about 70. And then on the harm side, this is very, this is almost pure speculation because we don't really know. This harm is only going to be in patients who are inappropriately prescribed tafenoquine. So, in any real world use of these point of care tests, there will be, some mistakes made, and occasionally you will get a fully deficient patient who gets prescribed this drug. And so you might expect, say, 1 hemolytic event per 1,000 patients, and maybe if you increase the dose, that might go to 2 per 1,000. And I'm not saying what the optimal dose is, but defining the optimal dose is this trade-off between this very uncertain risk in a very small subgroup of patients versus a very clear benefit in the very large majority of patients. And I think the key takeaway here is we now need some double-blind randomized trials which are comparing higher dose tafenoquine to the standard, to the current dose. And this will allow us to better assess the risks and the benefits. So I'd like to thank co-authors on this paper, especially Rob, who did a lot of this work with. And if you're interested, please read our eLife paper. And I'd also like to thank GSK for providing access to all their data. Thank you very much.